movement. It is not a rigid connector. Rigid connectors are indicated in cases of short span FPD. Short span FPD is a FPD where only a single pontic is present, right? When we have a pier abutment, we give a non-rigid connector, and the position of the connector is important. Remember this is that, see, if okay, so the if ideally if I have to see, so remember this, the male and the female where I have to attach, I will break the forces on the distal aspect of the, I will just again enlarge this image so that you are able to see. Okay, so if you are able to see this, I will give the non-rigid connection at the distal aspect of pier abutment, right? Okay, now if I am giving this, remember this, there is a mesial pontic and there will be distal pontic. So I will break my FPD into two parts: the anterior FPD involving the canine, first premolar and second premolar, and the second FPD will be second molar and first molar. Okay, now here the first premolar is a mesial pontic, and the first molar will be the distal pontic, right? So on the distal pontic, the mesial side, we will attach the male portion, and on the distal aspect of the pier abutment, we will add the female portion, right? This is important. We cannot change the position of the male and the female. Why? Because if we change the position of the male and the female, then there will be problem of unlocking, right? So pier abutment case, better we deal it with the help of your non-rigid connection. Now if this is the situation, why I am showing you pictures, because if this is the situation, so the question may be asked is that what is the best possible treatment? Okay, you leave about the caries. First of all, definitely we will just restore the caries teeth. But if it is given that we see that there are tilted teeth, so if somebody asks what is the best treatment of choice for such case, if we have to treat the case with FPD, so the best treatment advisable to replace FPD is uprighting of the molars or the premolar both here. The best option is uprighting. What are the other options? Other option is telescopic FPD, the mesial half crown. Okay, then we can give non-rigid connectors, or remember one thing, if the angulation, this is given in national dental boards, is that if the angulation of the tooth is more than 22 to 24 degrees, then nothing can be done and the intentional root canal has to be performed, and then we can give a normal FPD. Why? Because then we can cut it. If we try to prepare the teeth like this, then the pulp will be exposed. So we have to be careful. So in such case, in case of tilted abutments, if there is a picture, if there is a case that is given, remember that the best possible treatment is orthodontic uprighting. Other option I have told, telescopic is your double crown or a telescopic crown or a conus crown, CONUS or KUNUS. In that, what we do is we give two copings. First coping is the angulation correction coping. Okay, we just prepare the teeth, and the proximal and the distal surfaces, those are made parallel with the help of surveyor in the wax pattern stage. We cast them, we cement them. When we cemented it, then that means we have corrected the path of insertion with those, and then we make another impression and just make another FPD. So there are two crown within a crown, telescopic FPD. Okay, now but this has been asked so many times, and again I'll just enlarge the picture so that you people are able to understand that. Okay, so I hope this is you are able to see this. Just wait. Okay, So this is a Rochette bridge. This has been asked earlier. I have specifically taken pictures which have been asked so many times. Kindly don't get confused. If you see, there is metal retainers, इनको हम बोलते हैं winged retainers. This is a part of resin bonded FPD. This is a part of resin bonded FPD. So we will learn about, there are three types of resin bonded FPD. These are very conservative types where the preparation is only done. I will show you the next picture of the preparation also. But the first resin bonded processes that was given was the Rochette bridge, where you see there were conical perforations on the winged retainers and it was cemented. So the problem that came was that when it was given, so the cement line was exposed and it used to frequently got de-cemented, right? But then to correct such thing, then came the Maryland bridge. It was a solid retainers which were being bagged on the lingual aspect of the adjacent teeth, and they were being cemented by micromechanical retention, okay, with the help of your resin cement. Third bridge that was given, if somebody asks you, that is based upon lost salt technique. Remember, this lost wax technique is definitely your casting procedures, where actually the wax is burn out and then we do the casting procedures. It has to happen if we are using the mold and the casting procedures. But then the Virginia bridge, the indentations or the roughness was being created when on the wax pattern, on the tissue aspect of these retainers, the wax was sprinkled, okay, and then it was lost during the burnout procedure, and those indentation that was recorded again in your casting. So if somebody asks you, Virginia bridge was based upon lost salt technique. Remember this lost salt technique. So this is the preparation. If somebody asks you what is the preparation, so you can see the resin bonded process is being prepared only on the lingual aspect. We don't go on the too much proximal and on the incisofascial aspect. We are limited only on the lingual aspect or the parietal aspect, okay. We are replacing one teeth, and you can see we can give grooves on the proximal aspect, and these indentation that you are seeing, these are called as seating grooves. These are very specific to your these resin bonded processes. So if we give the seating grooves, so when we make the impression, even in the wax pattern, they will be triangular, triangular, the convexities, where it will fit into these indentation, and these will prevent the slipping of the prosthesis, and also will help in the seating. It will guide in the seating of the prosthesis over it. The major problem with your resin bonded processes is that it comes out very easy. It might come out, it can get de-cemented very easily. Then it might be a problem that it is an intermediate process. Remember, intermediate मतलब कुछ समय के लिए. For implant, अगर आपने इसके नीचे implant दे रखा, if you have given an implant here in the edentulous space, even without preparation, we can just etch and bond and just bond it for some time, till the time we are giving an implant processes. So we can give a resin bonded processes. For now, even there are materials like zirconia, where we are, earlier it was only metal, but now even zirconia can be given for such processes, and we have a lot of case reports where they survive the measure of time. But for all practical purposes, normally you will be given the wing retainers in metal. So it is a resin bonded processes where you have wing retainers in all metal, right? One more thing is that because these are very thin teeth, So from the label aspect it may cause graying of incisors, graying. तो वो जो the metal effect, the graying of the metal, the it can be observed from the observer can be observing these, the graying of the of the teeth, so it's a disadvantage. Okay, so if this is asked how to treat this case, so you, and if I have to rehabilitate the lower molar, so what should be done? Okay, so if this is given, so these, so lot of confusion is there. So you can see a lot severe extrusion. If we see severe extrusion and we see that the bone support of the teeth is so much compromised, okay, so in such case this molar has to be extracted, the upper molar has to be extracted. So if it is given that severe extrusion and nothing is given, 2 mm 1 mm, so normally if it is mentioned in the question that there is a mild extrusion or mild to moderate extrusion, still it can be treated by either by, if it is a mild extrusion, so we can just do the enamelloplasty and can go ahead with replacing it by either by FPD, lower FPD, or implant. Okay, now if it is given mild to moderate, then we can do intentional root canal of the molar, and what we can do, we can just give a single crown, all metal crown, or a PFM crown to take it to that level, and we can create space in the opposing arch. If this picture is given, so it's a severe extrusion. Okay, the bone support is compromised of the maxillary molar. In severe extrusion we tend to extract the teeth. Remember this, we'll extract this teeth. Okay, we can place an implant in the upper, or do an FPD in the upper, and same way we can rehabilitate the lower 7, like this case, right? I hope it is clear. So if in the question it is given severe extrusion, nothing else is given, go for extraction, no problem. If it is given mild, enamelloplasty. If it is given mild to moderate, okay, so you have to do intentional root canal treatment of the maxillary molar. Okay, go for intentional RCT, go for the occlusal plane correction with the help of a crown, and then we can rehabilitate the opposing arch molar, second molar, with the help of an implant or with the help of a FPD, right? Okay. Now what is this? So if you see this is a loop connector. This is a loop connector. If sometimes the patient comes to you that I have to maintain, if an FPD needs to be given, or if a patient says kindly maintain my diastema, some people feel that by closing the diastema the amount of money will reduce, or it will create bad luck, it will create bad omen. So such patient requests that please, if you can maintain the diastema, midline diastema. So in such a case, if such a patient comes to you, so there the loop connectors can be given, where they are connected at the palatal aspect on the gingiva, palatogingival aspect. It can be given and can be cemented, so you can see that you can maintain the diastema, and you can do such case with the help of this, right? Got it? If you are giving an FPD, right? So these are loop connectors to maintain the midline diastema or even more diastema. Got it? I hope it is clear. Okay, now this is important. So if you see, we have sanitary pontics, where sanitary pontics normally are pontics which are mainly indicated in the mandibular posterior region, where aesthetics is not important. So we know that the gingival aspect of the pontic, there are thousands and thousands times these questions are being asked, that what are the gingival considerations of a pontic. So the gingival consideration of the pontic, it said if it is contacting the gingiva, then it should be a point pressureless and passive contact. It should not create proliferation of the soft tissue. It should be hygienic. Patient should be able to clean it, right? So if it is contacting, then these are the features. If it is not contacting, then we should have at least 2 to 3 space where the patient can put their interdental cleaning aids and can remove the food debris that is being lodged. Okay, so we tend to create a 2 to 3 Now we have a sanitary pontic, that is a conventional, and then we have a modified sanitary pontic. The conventional sanitary pontic follows the ridge contour. This is known as fish belly pontic. This is conventional pontic, fish belly. Now, in various cases where there is another modification of this sanitary pontic, this is the second one, that is modified sanitary pontic, and it is also known as, if we can say, it is also known as parallel pontic. Parallel pontic, PEREL. Even we can say it is known as arc-shaped pontic. Arc-shaped pontic. So if it is given that what is this pontic, then we can say that it is parallel pontic, modified sanitary, or arc-shaped, ARC, arc-shaped pontic. The major advantage of an arc-shaped pontic is that we get a better connector length. So let me talk something about the connector width and the length and the area. So remember that if some question is asked that if we are going for an FPD with a reduced interocclusal space, which type of pontic is given in this mandibular posterior area? So in mandibular posterior area, if we are going for a FPD, then we can go ahead with the all metal crown, or with a modified sanitary or a parallel pontic, where with such a pontic design we get a better connector area. If somebody asks that what is the minimum connector area, length and the width of the connector area for all metal or PFM, it is 3 by 3. Remember this, 3 by 3. If somebody asks what is the connector area or the length and the width of the connector area in all ceramic or zirconia, it is minimum 4 by 4. Why? Because at the connector area maximum forces are being directed, and you see maximum fractures at the connector area. So again I repeat, for all metal minimum requirement is 3 by 3 for all metal, or for metal, and for all ceramic minimum we go for 4 by 4 right? So this is important. What is the pontic that is being advised in such a case? So many times, frequently this has been asked, so many times, right? So in such a case where we see is a recent extraction socket, we see there is a depression. Okay, so we go with the ovate pontic. The most aesthetic pontic is ovate pontic, and where we are seeing the extraction socket defect, definitely the answer is ovate pontic. It is the most. Why? Because it gives the best emergence profile. It gives the best emergence profile. I am writing best emergence profile. It gives the best emergence profile. It gives the best aesthetics. Okay, so in such a case where you see an extraction socket, if the extraction socket was not given, then for all practical purposes we go for a modified ridge lap pontic. If somebody asks what is a steel pontic, it is a modified ridge lap pontic. The modified ridge lap pontic is indicated in aesthetic zone, maxilla, mandible, anteriors, and maxillary posteriors. It is the most versatile pontic, where it can be used in almost each and every situation, right? And also it has a T-shaped contact. I'm again writing the modified ridge lap may it has a capital T-shaped contact with the with the ridge, and it is the only Pontic, it is the only Pontic that satisfy or each and every requirement. Point contact, it has a point contact on the label aspect, pressureless contact, hygienic and everything excellent, no doubt about it. Clear? Next, see, there have been so many instances where it has been asked about the, what is the best material of choice. If this is given, what is the best material of choice in replacing the anterior bridge or anterior crowns? So the best material to replace such is your pressable ceramics or the E-Max crowns. E-Max crowns. And E-Max crowns are pressable ceramics, right? Giving excellent aesthetics, right? Where they even take the color of the surroundings, just some camouflage, we say it is a camouflage effect. But you have to be very, very careful that they, especially veneers, E-Max veneers, where you are giving, that they even take up the color of the cement that you are using. So you have to be very, very careful. Before cementation, if you show it to the patient, the color is different. But when you cement it, because those veneers are very, very thin, so there you see that the color might change, right? So the patient will say, earlier so there are trial cements, you can mix it with the glycerin and you can go ahead with the cementation of the veneers. So here, if somebody asks you which is the bestest of the material where you want to cement it, where you want to for the anterior replacement of the teeth, best aesthetic material is E-Max crowns or the pressable ceramic crowns, or we can say lithium disilicate, LIDC crown. LIDC, short form is lithium disilicate, is LIDC, LIDISI. So where we say it is E-Max press 1 was lithium based, okay, but the E-Max 2 have aesthetics as well as strength. So lithium, those were lithium disilicate crowns, right? Maximum, where now we are giving lithium disilicate crowns. And remember this, that these E-Max crowns, these are to be cemented with the help of your dual cure cement or visible light cure cements. Okay, now what it is, so this is a type of shade guide, that is by the company Ivoclar. Leave it, companies leave it. तो अगर कभी क्वेश्चन आता है, you should know the order of the arrangement of the value, where A, B, C and D, it will tell you the hue of the shade guide, and A1, A2, A3, A3.5, we are increasing the chroma. And if we are to arrange this in the value form, so it is B1, A1, B2, D2, C2, like this we can arrange it in the increasing order of the value. So this is a if the question is asked, this is a Vita shade guide. There are some questions, the shade selection needs to be done in a natural daylight or in a wavelength corrected lights. Okay, the surroundings or the surrounding walls has to be in a pastel colors like light blue color or the the light gray color, blue color or the light gray color. If we have to choose between the blue and the gray, if given, or agar inme se if you have to choose one, then gray color is the best color. Why? Because these colors, when we are doing shade selection, the answer is the minimum time at a time when we can differentiate the color is actually 5 seconds. After 5 seconds, we get a color fatigue. So to prevent this color fatigue, to replenish the color pigments, we have to see against a gray or a blue background. So when we have to see against this gray or the blue background, so these are complementary colors to the colors that our tooth lies in the yellow or the yellowish red color, right? So we have to see against those backgrounds. Our patient should be at our center of the eye level. Okay, the teeth, before crown preparation you have to choose the shade. Okay, after crown preparation you don't check the shade. Before crown preparation you have to check the shade. So in PFM it is asked, the most difficult problem in a PFM is shade selection. The answer is shade selection. Why? Because it has a metal backing, so whatever shade we select we get a more of an opaque appearance. So this is a normal conventional Vita shade guide, the manual system of shade matching. If somebody gives you this is a Vita 3D master. Okay, so I'll just explain this. Kindly have a look. I will just explain this. The Vita shade guide 3D master. If somebody asks you, if you can see these numbers 1, 2, 3, 4 and 5, and this is the जो सबसे पहला the shade tab you are seeing, this is the first one is the bleaching shade. Leave it now. Okay, 0 is the bleaching shade. 1, 2, 3, 4, 5, these indicates the value. Remember one thing is that the conventional Vita shade guide, it is mainly in the order of selecting hue first, then chroma and last value. The normal Vita shade guide. If I am talking about the 3D master, then remember one thing, it is the value that is most important. The first one that to select, then the chroma and last is the hue. Now understand how. When we are using this Vita 3D master, so what I will do, if you see that you can see 1, 2, 3, 4, 5, these signifies the value of the tooth. Then you see that in every value there is M, 1M, 2M, 3M. So on this there is a tab, 4M. This is a sample shade. So first of all we will check this on which value our teeth lies. So what we are going to do, we are going to remove the center tab, 3M, 2M, 1M, and if so one of the tabs will match. Okay, no problem. Then the same tab we can see that there is the 4M. You can see 3 tabs. So when we are going up, the chroma is increasing. So if 3M1, 3M2, 3M3, it says 1, 2 and 3. So 3M1 is a lower tab, 3M2 is the middle tab, and 3M3 will be the upper tab. So when we are moving from 3M1 to 3, so the chroma is increasing. Okay, so then we will check the chroma, and last we will see that you can see it is given L and R. So L signifies the yellow hue and R signifies the red hue. So when we are selecting, if we have selected 3M2, so it will be very close to 3L 1.5. So ये जो L वाला है, then you have to go with L. So 3, the value remains same. It is in the range of the same chroma, but it is in the yellow range. If you just check the 3R also, so 3 is the value remains same. Remember this. So if it is in the L, so that means it is in the yellow hue. If then check R also, 3R, so that means जो भी whatever matches, so you have to write and given the shade. If I say that 3L 1.5, so 3L 1.5 what says 3 signifies the value. L signifies that it is in the hue range of yellow. 1.5 means a chroma is actually 2 or 1.5 to 2. It is the middle chroma. If I say 3R 2.5, is ऊपर वाला है 2.5, so it says that we have a 3 value. It lies in the red range and the chroma is also more, right? So this is how this covers more tooth shades, so that you can give a better shade selection. Nowadays we have digital ones, you can use those, no problem. Okay, so then what is this? It is an occlusal stabilization splint. So these are the parts of reversible occlusal therapy, where the patient is having a TMJ, an occlusal muscle disorder has set in. okay, then the first thing that we have to give is we have to go for reversible procedures rather than going for selective grinding and all sort of therapies. First thing is that we should always give an occlusal stabilization splint. These are permissive splints where there are no occlusal, there are no occlusal indentations, and it is just the flat surfaces the teeth are contacting. So when the if so by giving this patient around for around 6 to 8 weeks, patient has to wear it for around 20 to 22 hours. So the occlusal interferences will be gone. Why? Because we are giving a splint. So then if those occlusal interferences are gone, the lower teeth are contacting at the flat surfaces, the condyles will be free to go in the centric relation. So centric relation, it is, if I make you understand the definition, is that the condyles will it is a maxillomandibular relation where the condyles will articulate in the center avascular portion of the disc, okay, with the complex in anterior superior direction against the slopes of condylar eminence. It is independent of tooth contact, and it is basically a pure hinge movement, okay. So the main role is that our condyle should be in the centric relation position. So these occlusal stabilization splints, it will help in as a diagnostic splint also, and also as a corrective splint also. So it will reduce the pain immediately if there is a problem with the occlusion, right? Now if there is a problem, that if question is that there is retrodiscitis. Retrodiscitis is that when the condyle is actually shifted posteriorly, right, and it is hurting the retrodiscal tissues, which are very vascular, which are very neural in nature, where there's a lot of nerves present over there, so patient will experience a lot of pain. So then we have to, what we have to do, then we will not give permissive or stabilization splint. Then what we will do, we will give a anterior repositioning splint, or we say directive splint, where what we will do is we will just make the impression maxilla mandible, and we will take a protrusive record like this, where the mandible is taken in the more forward position, and then we will give indentation so that the mandible locks in a forward position, and then we close it, right? So in such a case, if we have done this, so the even the condyle shifts forward, okay, and the retrodiscal tissues, they heal, and there are no problem at all. It takes some time for healing. It heals by fibrosis, and the pain will be reduced. So we are directing the mandible forward so that the condyle shifts forward and the retrodiscal tissues are not harmed, right? So patient will again, the pain will be reduced, okay. Now what is this technique for, if you see, कौन सी टेक्निक मानी जाएगी अगर ऐसे आता है तो? So if you see, the putty impression is already being taken, and then it is already set, and then we are injecting a light body. So it's a putty reline technique. It's a two-step technique, right? So it is being taken in the stock tray, where we first mix the base and the catalyst for putty, and just we make a normal impression. Now we can create space by two things. Either we can create space in the first impression when we are taking with the putty, we apply a polyethylene sheet, make the impression so it will not flow into the interproximal areas, and then we can just inject light body in the trough, and then we can make another impression, okay. Or we can just use a putty cutter. After making the impression, we can reduce the interproximal areas with the help of putty cutter, and then we can create space for the light body and can make the impression once again. So it's a two-step technique. Remember this. It's a two-step technique where we have to again place the impression in the patient's mouth. But the only problem is that, first of all, we don't know how much, because these are viscoelastic materials. We don't know how much amount of pressure we are placing, and there may be some problem of the orientation of the impression again in the same place. Sometimes it happens that there are reorientation problem, because it's a two-step impression technique. Maybe possible there might be some so you have to reduce all the undercuts, anteriorly, labial undercuts, जो भी है, you have to reduce it. Otherwise, it will not seat, and there will be a lot of distortion in the impression. So the question comes is that in the putty line technique, what is the major problem? The major problem is that we don't know, are we reorienting the impression at the same place second time or not, right? So putty reline technique. Okay, then what is the procedure? This is a procedure. After preparation, we have to do gingival retraction procedure. So this is a gingival retraction procedure where you can see a retraction cord. Maybe it is soaked in a hemostatic agent or any gingival traction cord solution, and it is packed. Remember this, there are a lot of questions that have been asked. Okay, to now, what is the main function of gingival retraction? The main function of gingival retraction, first, when we have packed the cord, so the main function is to drag the gingiva or deflect the gingiva away from the subgingival margin, right? We tend to use this subgingival this retraction in the case of subgingival or equigingival margin. We tend to expose the prepared and the unprepared tooth structure so that our material can go and can record this area. First. Second, when we have done this, second important function of gingival retraction is that we need a clear field. We do not want any blood or GCF or saliva. Why? Because most of our impressions are hydrophobic in nature. Only polyether is hydrophilic. So a material, for example, addition silicone, even the hydrophilicity is trying to be improved by adding some surfactant, no, but still it is inherently hydrophobic in nature. Either we can use hydrophilic materials, but if you are giving equigingival or subgingival margins, mind you have to do gingival retraction procedures so that you can get good impression. Otherwise, what will happen? If you don't get, the technician will not be able to differentiate between the soft tissue and the tooth, and then the technician will make the crown on soft tissues, right? So which is the best method? There are various methods of gingival retraction. If we use a single cord without any solution, it's a mechanical method. If we are soaking the cord or we are using anything and we are using a hemostatic, local hemostat agent, it might be a vasoconstrictor, it might be a hemostatic agent, it might be tannic acid, it might be anything. So it is the best combination. Chemico-mechanical method of retraction is the best method. Then there are various surgical methods, like we can use rotary curettage, where we can use a torpedo diamond burr and can reduce or remove the sulcular epithelium. It's a traumatic in nature. Rotary curettage method, right? जिसे हम बोलते हैं gingival troughing भी बोलते हैं, right? Last method is electrocautery. Electrocautery, we have to use a fully rectified current where we give a localized current and it will heat up and it will reduce, create some space, right? And there is the tissues in the sulcus will vaporize. It heals excellently well, but then you have to be careful, okay, with the pacemaker patients, okay, and then you should have the armamentarium also for electrosurgical procedures, right? Then you should also be understandable that when we are using a gingival retraction cord, there are two methods. In fact, there are three methods. One is single cord method, where a single large cord will suffice the gingival retraction. And if you see this picture, then there is a double cord technique. Double cord technique normally is done when we are preparing multiple teeth and when the tissues are not in their normal gingival health. Okay, so there the small cord is placed in the depth of the sulcus, and the large cord then is placed above the small cord and soaked in the hemostatic agent. We wait for some time. Normally the gingival retraction cord, question comes, the gingival retraction cord is placed in the sulcus for at least 8 to 10 minutes, and immediately we remove this and we make the impression. Do not waste time while because the gingiva is an elastic structure. It might cause elastic recoiling, come back to the and we see that the impression material doesn't go inside and doesn't record well. So in a two core technique, we don't remove the first smaller diameter core. Okay, got it? Then there is a dento infuser technique. Question asked, so that in that the hemostatic agent that is being asked in a dento infuser technique is your ferric chloride. Okay, sorry, ferric sulfate. Ferric sulfate 15 to 25, 15 to 20% ferric sulfate. Okay, ferric sulfate. If you see, it's a veneer. Okay, it's a stick. It's a sticky. You know, this is how the veneers are carried with a stick that has got a sticky material in the front. Okay, so the question that is asked, maximum time the veneers are made with a lithium disilicate material. Most aesthetic material, if somebody asks in ceramics, is a lithium disilicate material. The question asked is that which is the best cement for cementing such veneers? The best cement for cementing such veneers is a visible light cure resin cement. Remember this. If there is a crown, you can use your dual cure cements. Dual cure cement means, see, first of all, I will tell you there are three types of resin cements. One is your self-adhesive cements, second is dual cure, and third is completely light cure or visible light cure cements. Self-adhesive cement, there you can use it for all metal, zirconia, something like that, right? Because they will set by a chemical reaction. Dual cure have both the components, the self cure component and the light cure component. Now, why veneer is cemented with the help of visible light cure cement only and not, I am saying, that with the dual cure? The dual cure contains a chemical, right? So there, because of the chemical, chemically activated component also are present. So after some time, these undergo oxidation of tertiary amines, which might cause discoloration. So see, if the patient has come to you for a veneer and you have cemented it, today the color is okay, but after some time you see that the darkening, or you see that the veneers the inside color of the veneers is getting darkened. It is because you might have used a dual cure cement where the amines or the tertiary amines are getting oxidized and getting discolored. So how will the patient react? He will not react in a good way, and it will give a bad, you have to repeat the whole procedure. So do not use any chemical component in the cement. So always use, for veneers, always use visible light cure cement, resin cement. Got it? Got it? Okay. So for Emax crowns, you can use a dual cure cement. For cementation of Emax veneers, you can use a visible light cure cement. Okay, so in Emax veneers, you have to be careful that whenever you have cemented it, first of all you have to just do a tack cure for 5 seconds, both the sides, remove the excess, and then do complete 20 seconds or 20-30 seconds from all the sides. Remember that the contraindication, many times the question has been asked,